Thanks again for having me. I've been doing this for 15 years, but for quite a few, and it's always an incredible course and one of my favorite, and truly an honor to be here, especially to talk about deformity, which is certainly one of my passions. We heard a bunch about cervical deformity from Dr. Hamilton yesterday, so this is going to focus primarily on thoracolumbar. And adult deformity is important for a variety of reasons. For one, it's extraordinarily common. Depending on how you define it, it can be seen in up to 2/3 of patients over 60. Deformity has a huge clinical impact. This has been looked at many different ways. This is a nice study demonstrating that deformity has a similar burden as other major disabling chronic conditions. And what we know is that what we do is helpful and beneficial. This was a large study from the ISSG looking at patients treated operatively versus non-operatively. And you can see that patients treated non-operatively remain on their current path while we give patients treated surgically the opportunity to significantly improve. But it's not without cost. And this is part of what I think really attracted me to deformity to begin with, is that really the opportunity to get better. We're helping people, but there's a very high risk of complication. This study, 72% of patients had at least one complication. Many of these are mechanical. And so there's really a lot of opportunity for us to do better at what we do so we can help patients even more. Deformity can be defined lots of different ways. Essentially, adult deformity is malalignment in anybody of adult age by either scoliosis, kyphosis, or high-grade spondylolisthesis. It's been a long list of alignment parameters that have been looked at. Kind of distill this down to two sentences, but really what we know from the coronal plane is you want to be straight, and really globally is the most important piece. Having good global coronal balance is important. But it's really the sagittal plane that has been the focus of most of the attention because it's been associated with a huge impact on quality of life by a variety of metrics. And this was really the foundation for our deformity parameters from the sagittal plane. These were the three parameters that were most associated with quality of life. We really want to target get your PI minus LL within 10, your C7 SVA less than 4 or 5, and pelvic tilt less than 20. And this really became kind of the standard for how we try to get patients realigned. But it's become clear over recent years that it's certainly more nuanced than this. It's been introduced a variety of other philosophies and concepts. Virginia Lafarge and ISSG introduced this concept that maybe we shouldn't be trying to hit those parameters to that extent for all patients. We know that aging patients in general, even ones that aren't symptomatic, lose their sagittal plane, and that perhaps we should be undercorrecting some of these patients. And there's some evidence that these patients do better with relative undercorrection in terms of mechanical complications. There's been a lot of effort out of Europe. This is the ESSG. Developed this GAP score, which is a score you can actually calculate online. There's an online calculator based on a variety of parameters, and there's quite a bit to this. Really this was emerged out of the idea that with meeting the Schwab criteria, many patients still had mechanical failures, and this was introduced as a potential way of redefining our alignment targets with the idea that ideal lumbar lordosis may not be as simple as just that mismatch of less than 10 degrees, and that pelvic tilt varies with your pelvic incidence, and that the distribution of lordosis matters. And I think that's been clear for a while, that distal lordosis is of critical importance. The concept for a while was that your distal lordosis from 4 to 1 should be roughly 2/3 of your lumbar lordosis. But it's become clear from a variety of studies, including this one, that actually that L4 to S1 lordosis is pretty fixed, independent of your PI, and it's actually your proximal lordosis that varies with increasing PI, as you can see in this study here, with the increased pelvic incidence having greater proximal lordosis. Ruesli classification, another important concept, essentially describes various shapes based on pelvic incidence, and demonstrating that failure to restore Ruesli shapes may also be important for having good mechanical outcomes. So once we kind of, while we're assessing patients, we're, when I see a deformity patient, these are kind of the three main questions I have. So, one is the, deformity primary to the complaint. And, I think we're in this deformity era, we all see an elevated C7 SVA, and there's a tendency to want to go in there and fix it. But that first question is really important. We see a lot of patients with a elevated SVA that don't necessarily have malalignment. If you do the numbers there, the pelvic tilt's not elevated. There's not a significant amount of mismatch. This is really a lumbar stenosis patient that just needs to be decompressed. So let's say the deformity is primary to the complaint. Is deformity correction necessary? Do you have to fix the whole deformity in order to achieve a good outcome? Or can you do either a single level reconstruction or maybe even a foraminotomy? And then even if the first two answers are yes, is this patient even a good surgical candidate? With the high complication rate and adult deformity, we really have to be careful who we're taking to the OR and doing these massive operations. So assuming those three boxes are checked, this is the next really most important thing for these patients, especially older patients, is getting these patients optimized for surgery. And so there are a lot of modifiable risk factors that we need to address. Here's a list of several: osteoporosis, obesity, opioids, which are common for people with managing these chronic pain issues, diabetes, tobacco, and there's a wealth of data in deformity and in the DGen literature demonstrating how important it is to address these factors, and that this does have an important impact on patient outcomes. So for treatment planning, decide you're going to do a deformity surgery, and I think the most important thing is first to characterize the deformity so you can understand what you need to do. What's the location of the deformity, the magnitude of the deformity, and one of the most critical things that's going to dictate what you need to do is it flexible or not? Is this a mobile deformity? Is it a fixed deformity? And then coming up with your plan. And the plan has a lot of different layers to it. How long are you going to go? How high, how low? What type of osteotomies you need to do to loosen the deformity so you can get the correction you need? What levels you need to decompress? And then what type of instrumentation you're going to use? This is a rapidly evolving field with a lot of technology, a lot of different implants, interbodies, screws, materials. Which instrumentation are you going to use for your patient? And then ultimately for this, whatever you do, it's not going to be durable unless you get good arthrodesis. So planning a good arthrodesis so that you can get solid fusion so the patient could have a good durable outcome. In this case, needed to do a 3-column osteotomy to achieve our goals. So let's run through a couple of cases. So this is a patient that presented to me like this. This is a gentleman in his early 70s, I believe. Who had this, rapidly progressive, multiplanar deformity. Here's some of the numbers. And interestingly, he was established at our institution with another surgeon, and we had some long length x-rays dating back to 2017. You can see back in 2017, actually had pretty normal alignment, had a pain pump, and over subsequent years, you see this kind of evolving deformity, pretty rapidly progressive, and this is where he was when he presented to me. Given the way that behaved, we did a full neuromuscular workup to try to get a better understanding of what was driving that deformity. And essentially all that was negative aside from his chronic pain. So, working through my algorithm, trying to define the specific deformity. The way I like to evaluate flexibility is I get CAT scans on essentially all my adult deformity scoliosis patients. And you can use the scout images from the CT to eliminate gravity and look at flexibility of your deformity. And here you can see some flexibility and some restoration of normal alignment there, not full correction, but some. And the same thing in the coronal plane. If you drop a T-bar, though, you can still see it's still significantly malaligned. If we dig into the individual cuts, we can see that really there's a fixed, really focal deformity at L1-2 there. We're driving, there's significant scoliosis there at L1-2. very rigid. You can see in the thoracic spine, those vacuum discs, the curvature there actually relaxes very well with gravity eliminated. And the same thing in the sagittal plane, L1-2 with a fixed kyphosis and relative flexibility elsewhere. The L4 to S1, a little bit off target, but not terrible. And so for this, decided we need to really do something, long and substantial, given the magnitude of the deformity, despite it being really a focal problem at L1-2, worrying about going shorter on him and not addressing his severe sagittal plane. So here we spent most of our attention correcting this at L1-2, which is really for a deformity correction was relatively straightforward despite that magnitude of the curvature. And so what I like to do is make sure in surgery we're accomplishing what we need to before we get off the table. I use these stitch images to help assess the alignment in surgery in the coronal and sagittal plane. And here's what we accomplished, and really just by releasing that level L1-2 with a disc-based osteotomy, able to really open that up and correct the scoliosis at that level, and also the kyphosis in the upper lumbar spine, and able to hit our realignment targets.
Beautiful. Beautiful.
It's a pre to post. And kind of an impressive change, but really all it took was that work at L1-2. So, not a lot of work to get there. So it's another case. This is it's kind of shows some of the things that have evolved in my practice recently. This is constantly, kind of evolves for me for sure. This is a 69-year-old, had a 4-5 TLIF in 2019 and developed progressive back and leg pain. You can see the adjacent segment stenosis, 3-4, 2-3, and a little bit at 1-2. Past medical history significant for neurosarcoid and pulmonary sarcoid. This was debilitating. He had multiple hospitalizations, been relatively stable for a couple of years after presentation, but that definitely caused some problems for him. On the surface with the stenosis these flex X's appears to be kind of a degenerative problem. Our institution recently got these long alignment whole body X-rays, which I think is really shows things very differently. So you can really appreciate here from these two slides, really looks like a degenerative problem. You can really appreciate how this is a major spinal deformity based on the spine, but also you look at all the lower extremity compensation, the hip flexion, the knee flexion. This patient's really fighting to stand upright. And if you look at the numbers, this is primarily driven by a high pelvic incidence of 84 with a very high mismatch of 69, but all coming really from the proximal lumbar spine. He's got really what he needs from 4 to 1 based on what we've learned over recent years, kind of in that 35 to 40 range. So we look at our supine scouts from CT. You can see that in the coronal plane, he relaxes pretty well and corrects, and that there is some correction in the sagittal plane as well. You can see those vacuum discs. So really, where the deformity is those mobile segments from L1 to 4. But with a PI of 84, we obviously need to do quite a bit more work to take him from 36 up closer to where he should be in the 80s. And so, with these mobile segments, we know we can get our correction without having to do an aggressive 3-column osteotomy. But we know with the delta that we need at those 3 levels that we're going to have to do some work. And so the plan was to do some posterior column osteotomies with T-lifts where needed. And these high PI patients have a tendency to go up to the upper thoracic spine. Given his comorbidities and some concern of him tolerating an operation there, we decided to stop at T10, and if he did develop PJK, we could extend him later. These are kind of the bells and whistles I use. I've evolved to add more distal fixation to reduce that high rate of distal failure we see. Multiple rods across the lumbosacral junction. I cement at the top, and I tether to help with that PJK risk. And so, part of my evolution has been using these custom rods, which has been very helpful. For one, you make sure you have the right size rod. The previous case, you could see actually and really highlight it. But at the top, I had to do a little extension, which I created like kind of a soft landing with titanium. But what drove that was I didn't have rods long enough to go up to the top. The guy was a very tall patient, and the custom rods, really allow you to plan ahead of time and have exactly what you need for surgery, and allows some really nice planning software as well. And so we can see what we need to do here. We have to get close to 20 degrees at L1, 2, 2, 3, and 3, 4. And so that's where we're going to spend our most of our attention. And so that's where we did our work at a couple of T lifts at 2, 3, and 3, 4, and really trying to hit those goals. And here's where we started and stopped. And I love it's new to me, especially as a neurosurgeon, looking at the lower extremities. But you see that wide base gait preoperatively, the flexed hips and knees, and how these are, I think it was 3-month post-op X-rays, and that dramatic correction in lower extremities, a more narrow based gait and stance there, and all that compensation of the lower extremities, which has been really interesting for me to observe. So to summarize, adult deformity is extraordinarily common. We know that properly selected patients benefit from surgery, but we have to, keep evolving so we can really drive that complication rate down. As I said, this is a great venue for me, and decided to bring my family out this year. I was looking back. Last time I brought my family out was in 2015, when the family looked like this. This was right after I had my firstborn, Anthony, and got him out here now. So you can see how the family's grown, and they're out there having a blast, touching gum balls and space needles and everything else. Got a Mariners game tomorrow, so been a real pleasure being here, and happy to entertain any questions. Thank you.
Jane, that was beautiful, beautiful cases and just very elegant summary. Now, quick question. What's going on? Why are we having so many more deformities? Are we measuring too much and expanding the scope of definitions? Or is there something going on with the society that's just profoundly different? I mean, these are horrible cases that you've done here. Beautifully done. But what's going on?
Yeah, I mean, I think it's a few different things. I mean, one, I think the pendulum has swung. I think we under-recognize deformity and the importance of alignment. People were getting locked into wherever they happened to be, and I think people became more cognizant of the impact of that. And as we become more aware and we start measuring everything, I think the pendulum has swung the opposite way, that everything that's off by a couple degrees now gets a big case. I think I think it starts on the degen side. I think the more aware we are of these concepts, hopefully, the better we can do at preventing needing to do these types of things. But it's certainly a massive problem, and as we age, people degenerate in significant ways, and often that requires substantial reconstructions. But we have to be careful who we're doing it to, because it's a big surgery and a big impact.
Then the other thing is, again, beautiful cases. But what do you do proximally or rostrally? This is not a talk about adjacent segment failure or so, but did you put some invisible bands around it?
I did, yeah. Yeah, so I do. I mean, PJK is still, PJK, DJK, those are our two biggest problems. And so I've been doing belt and suspenders on the top and bottom to really try to eliminate some of that failure. And I think it helps. In my own practice, I've looked at the rates, and it has decreased a bit, but it's hard to study because I've made many changes altogether. But yeah, I do. I cement the top to help reduce bony failure and screw loosening, and I band the top to reduce ligamentous failures. And I think it makes an impact.
Yeah, I mean, if I may editorialize, those are very rewarding cases if everything goes well, and that would certainly look like that. But my biggest worry is that we're over evaluating numbers or concentrating on numbers and not seeing the whole gestalt of the patients, their muscle mass, their psychometrics, etc. So any thoughts of optimization? You probably hardly ever operate on these people right away. You kind of get to know them for a while. Because they become part of your family also, right? Expanded family.
Yeah.
So how long do you get to know patients, and who controls their rehab or prehabilitation?
Yeah, we do. So, some of them have already been down that path and already kind of getting optimized before they see me. Most of them have not. And so our initial visit is kind of educational, and we get them plugged into doing all the things they need to be doing. And we work on optimizing all those factors. But Absolutely right. We don't just see them, talk for 10 minutes, and then drop 30 screws in them. It's a process. It's a relationship. It's intimate. I mean, you're with these people for a long time. These are, kind of butterfly cases showing good radiographic outcomes, but it's often complicated, and you have to really make sure you're doing well by your patients and taking care of them. So,
Well, thank you.
yeah, thank you.